Ever had that sudden weird ache in your belly? And you're just wondering, what on earth is actually going on in there?
Well, today we're doing a deep dive into the really complex world of your digestive system. We're focusing specifically on the stomach and intestines. Our mission really is to take all this detailed medical info stuff like where pain points, what exams mean, treatment strategies, and kind of distill it down, make it into actionable, maybe even surprising nuggets of knowledge for you. Think of it as your shortcut to understanding a super vital part of your health.
Exactly. And we're not just, listing facts here. We want to connect the dots, help you understand the why behind symptoms, what they might really mean. But quick disclaimer, and this is important. This is fascinating stuff, great for understanding, but it's absolutely not for self-diagnosis. Always talk to a healthcare professional if you've got medical concerns.
Okay, absolutely. So let's jump right in. We're starting with something pretty fundamental that doctors use all the time to narrow things down, the abdominal quadrants. It's basically like creating a map for your insides, right? Precisely. Think of the abdomen divided into 4 sections. You've got the right upper quadrant, left upper quadrant, right lower quadrant, and left lower quadrant. It's like a quick grid system. Helps pinpoint where the trouble might be.
Okay, so 4 zones. How does that help?
Well, each quadrant tends to point towards a specific set of acute problems. So in the right upper quadrant, the RUQ, we often think about cholecystitis, that's gallbladder inflammation, and hepatitis, which is liver inflammation. And a really key clue here often is that pain from cholecystitis. It's frequently triggered by fatty foods.
Ah, that makes sense, because the gallbladder helps digest fat.
Exactly. It releases bile, especially after fatty meals. If it's inflamed or there's a stone blocking the way, that contraction causes intense pain. It's a direct link that really helps guide diagnosis.
Okay, moving over to the left upper quadrant, or LUQ, common issues causing pain there. Pancreatitis, inflammation of the pancreas, though that pain can sometimes be more central in the epigastric area too. And you might also get pain there from gastric ulcers, those sores in the stomach lining. Got it. What about the lower quadrants?
Down in the right lower quadrant, the RLQ, the absolute classic condition that springs to mind immediately is appendicitis, inflammation of the appendix.
Right, everyone's heard of that one.
And then finally, the left lower quadrant, LLQ. Pain here often points to diverticulitis. That's when these little pouches called diverticula that can form in the colon get inflamed. Treatment for that usually involves, pain control, resting the bowel with a liquid diet, and sometimes antibiotics if it's a more complicated case.
Okay, so that quadrant map is a really useful starting point. Now let's dive deeper into some specific conditions and those really interesting physical exam signs doctors use. Let's start with appendicitis, that classic RLQ emergency we mentioned. The presentation is usually that right lower quadrant pain, right? Often with nausea, vomiting, maybe a bit of a fever.
That's the typical picture, yes. RLQ pain, nausea, vomiting, low-grade fever. For diagnosis, CT scans are generally the most reliable for adults. For kids, though, we often prefer ultrasound to avoid the radiation dose.
And the physical exam. You mentioned specific signs.
Ah, yes. This is where it gets fascinating. These signs are really crucial for doctors. It's like reading the body's signals in real time. Let's talk about a few common ones. First, there's the Bloomberg sign, or rebound tenderness. This is where the doctor presses down, then quickly lets go. If the pain is worse when they let go, that's rebound tenderness. It suggests irritation of the peritoneum, the lining of the abdomen. We remember B for Bloomberg, B for rebound.
Okay, rebound pain. What else?
Then there's Rovsing's sign. Here, the doctor presses on the left lower quadrant, but the patient feels pain over on the right lower quadrant where the appendix is.
How does that work?
Well, pressing on the left side pushes gas across the colon, which can stretch the inflamed appendix area on the right, causing pain. The mnemonic here is Rovsing refers to the right side pain. And another really specific one is McBurney's point tenderness. McBurney's point is a very particular spot. It's about 2/3 of the way from the belly button out towards the bony part of your hip. You can feel at the front the ACEs. Tenderness right at that point is highly suggestive. McBurney point for point tenderness.
Wow. Are there others?
Oh, yes, there are several more, like the obturator sign involving rotating the hip and the psoas sign involving lifting the leg against resistance. They all test for irritation around the appendix in different ways. The key is how these subtle reactions help build a really strong clinical picture.
It's amazing. But I guess one sign alone isn't definitive.
Oh, absolutely not. No single sign is 100%. But you combine these signs with the patient's story, their vital signs, maybe some initial lab work, and it paints a pretty clear picture that guides the next steps, like ordering that CT scan.
Okay, that makes sense. Let's shift gears. What about gallbladder and biliary conditions? We mentioned acute cholecystitis.
Right, gallbladder inflammation. And there's a really telling sign for this one too. Murphy's sign. For Murphy's sign, the examiner places their hand under the ribs on the right side in the RUQ and asks the patient to take a deep breath in. If the patient suddenly stops breathing in what we call a mid-inspiratory arrest because of sharp pain as the inflamed gallbladder hits the examiner's hand, that's a positive Murphy sign.
Ouch. Sounds really uncomfortable.
It is. These patients often look quite ill, really significant pain. If you suspect cholecystitis, they need to get to the emergency department right away. They'll need IV fluids, imaging, and often the definitive treatment is surgery to remove the gallbladder, a cholecystectomy.
How is that different from biliary colic? You mentioned that earlier too.
Good question. Biliary colic is more intermittent RUQ pain. It often happens after eating fatty meals, maybe with some nausea or bloating. It's usually caused by gallstones temporarily blocking the bile ducts when the gallbladder contracts. The pressure builds up, causes pain, but then the stone might move and the pain subsides.
So it comes and goes.
Exactly. But if that blockage doesn't clear, if it becomes persistent, that's when biliary colic can progress into full-blown acute cholecystitis. Diagnostically, we usually start with an abdominal ultrasound to look for stones. If that's negative, but we still suspect gallbladder issues, AHI scan can be done. That actually looks at how well the gallbladder is functioning, filling and emptying bile.
Okay, understood. Next up, pancreatitis. What does that pain feel like?
Pancreatitis pain is typically pretty severe, often in the upper abdomen epigastric or LUQ, and it characteristically radiates straight through to the middle of the back. It's almost always coupled with significant nausea and vomiting.
And what usually causes it?
The most common acute cause is actually gallstones getting stuck down near the pancreas. But heavy alcohol use is another major one, and sometimes really high triglyceride levels in the blood. We diagnose it using lab tests looking for elevated amylase and lipase and imaging like ultrasound or, for more detail, a CT scan with contrast.
And like cholecystitis, these patients seem quite sick.
Very much so. They often look extremely ill and need immediate referral to the ED for supportive care, pain management, IV fluids. And speaking of severe pancreatitis, there's a rare but critical complication, bleeding inside the abdomen. There are two really important, though uncommon, signs to know. One is Cullen's sign. That's a bluish discoloration right around the belly button periumbilical ecchymosis. Think Cullen for center. The other is Gray-Turner sign. That's bruising or bluish discoloration on the flanks, the sides of the abdomen. Flank ecchymosis. You have to turn the patient to see their flanks.
And those colors might look different on darker skin.
Yes, absolutely. On darker skin tones, it might appear more like a darker reddish or purplish area rather than distinctly blue, but finding either Cullen's or Gray-Turner sign, that signals a critically ill patient, likely with internal bleeding, who needs immediate transfer to the ED. Massive red flag.
Wow. Okay, one more acute emergency we have to touch on. Ruptured abdominal aortic aneurysm, or AAA.
Yes, this is a catastrophic event. The aorta is the main artery leaving the heart. An aneurysm is a bulge in its wall, and if it ruptures in the abdomen, it's often fatal very quickly. The classic signs are a pulsatile mass in the abdomen. You can actually feel a pulse where you shouldn't, combined with acute, severe tearing or ripping pain, often in the abdomen or back, and signs of shock like low blood pressure from the internal bleeding.
What's the immediate action?
Call 911 or your local emergency number immediately. There's no time to waste. They need emergency transport to a hospital for life-saving surgery. The mortality rate is incredibly high, so speed is absolutely critical.
Okay, these acute conditions are intense, and recognizing the signs is clearly vital. But, for a lot of people, digestive issues are more chronic day-to-day things. So let's shift gears and talk about some of those persistent challenges. Maybe start with something really common. GERD, or acid reflux.
Right, gastroesophageal reflux disease. Basically, stomach contents backing up into the esophagus, causing symptoms or sometimes complications. The main cardinal symptoms are heartburn, that burning feeling in the chest or throat, and regurgitation, where you feel stomach contents coming back up.
Are those the only symptoms?
Those are the most typical. But we really need to watch out for alarm symptoms. These suggest something more serious might be going on and warrant immediate referral and probably an endoscopy, an EGD. Alarm symptoms include things like difficulty swallowing dysphagia or painful swallowing odynophagia. Also, recurrent vomiting, especially if it looks like coffee grounds, which means bleeding. Or feeling full really quickly after starting to eat, that's early satiety. And of course, if symptoms just aren't getting better with standard treatment.
So if someone just has typical heartburn, what can they do?
Lifestyle changes are always the first step. Things like losing weight if overweight, definitely quitting smoking, avoiding foods that trigger symptoms, often acidic things, spicy foods, caffeine, chocolate, peppermint. And a simple but effective one is elevating the head of the bed at night, just using gravity to help keep acid down.
Makes sense. What about medications?
For mild, infrequent symptoms, say less than once a week, H2 blockers like famotidine taken as needed can work well. But for more persistent, moderate to severe symptoms, the go-to are the proton pump inhibitors, or PPIs. Things like omeprazole. These are usually taken once a day, typically for an 8-week course initially.
You mentioned something interesting earlier about PPI timing.
Yes. This is key for effectiveness. PPIs work best when taken about 30 to 60 minutes before the first meal of the day. They work by shutting down the acid pumps in the stomach, and those pumps are most active when stimulated by eating. So taking it beforehand gets the medication ready to work right when it's needed most.
Good tip. What if someone can't afford a PPI, or the H2 blocker isn't cutting it?
Well, if cost is the issue with a PPI, an H2 blocker is a reasonable alternative to try. If the H2 blocker isn't providing enough relief, then stepping up to a PPI is the next move. And if someone tries a PPI for 8 weeks and they're still having significant symptoms, or if they develop those alarm symptoms we talked about, that's when they definitely need to see a gastroenterologist for an EGD to take a closer look.
Are there downsides to PPIs, especially long-term?
Yes, there are considerations. While they're very effective, long-term use has been linked to a slightly increased risk of osteoporosis, vitamin B12 deficiency, and C. diff infections. This is partly because reducing stomach acid so significantly can affect nutrient absorption and the balance of gut bacteria. So the goal is always to use the lowest effective dose for the shortest necessary time. Also worth noting, some other common medications, like certain calcium channel blockers used for blood pressure, can actually worsen GERD by relaxing the muscle at the bottom of the esophagus.
And if GERD just goes untreated, what's the big risk?
The main concern is Barrett's esophagus. This is where the lining of the esophagus changes due to chronic acid exposure, becoming more like intestinal lining. It's considered a precancerous condition. Over time, Barrett's can progress to esophageal cancer. That's why treating GERD effectively is important, not just for symptom relief. And why just relying on antacids isn't enough. They're just a temporary band-aid. They don't heal the underlying issue or prevent complications.
Okay, moving on. Let's talk about peptic ulcer disease, PUD. Ulcers in the stomach or small intestine.
Right. And the two heavyweight champions of causing PU are infection with a bacteria called H. pylori and long-term use of NSAIDs, non-steroidal anti-inflammatory drugs like ibuprofen or naproxen.
How do you figure out if H. pylori is the culprit?
It depends. If the person doesn't have any alarm symptoms like bleeding, anemia, difficulty swallowing, then non-invasive tests are preferred. That's usually a urea breath test or a stool antigen test. Both are pretty accurate and easy to do. But if alarm symptoms are present, then an EGD, the endoscopy, is needed. That allows the doctor to actually see the ulcer, take biopsies to check for H. pylori, and rule out other things like cancer.
And if H. pylori is found, the treatment sounds a bit intense. Multiple drugs.
It often involves a combination, yeah. The classic regimen was triple therapy, a PPI plus 2 antibiotics, clarithromycin, and amoxicillin. The mnemonic CAP helps remember. Clarithromycin, amoxicillin, PPI. If someone's allergic to penicillin, metronidazole is used instead of amoxicillin. However, because of rising antibiotic resistance to clarithromycin, quadruple therapy is now often recommended as the first-line treatment in many places. That involves a PPI, bismuth subsalicylate, like in Pepto-Bismol, and 2 different antibiotics, metronidazole and tetracycline. A way to remember that is treat my belly pain.
How long do you take these for?
Typically for 10 to 14 days, and this is really important. After finishing the antibiotics, you need to test to make sure the bacteria is actually gone, eradication testing. This has to be done at least 4 weeks after finishing antibiotics. And crucially, the patient needs to stop taking their PPI for at least 1 to 2 weeks before the pest. Otherwise, they risk getting a false negative result.
Good to know. Okay, one more bacterial issue, C. diff. Clostridioides difficile.
Ah, C. diff. The classic picture is cramping abdominal pain and lots of watery diarrhea, often with a very distinct, really foul smell, the biggest trigger. Antibiotic use, especially broad-spectrum or long-term antibiotics. They wipe out the good gut bacteria, allowing C. diff, which can sometimes live harmlessly in the gut, to overgrow and release toxins.
Which antibiotics are common culprits?
Clindamycin is a notorious one. Fluoroquinolones and cephalosporins are also frequently implicated. Treatment now usually involves specific antibiotics like fidaxomicin or vancomycin, which target C. diff directly.
All right, let's shift focus slightly towards prevention and just understanding general bowel health. Starting with colorectal cancer screening, super important topic.
Absolutely critical, because, as we mentioned, early-stage colorectal cancer often has no symptoms. Screening finds it early when it's most treatable. Current guidelines for average-risk individuals recommend starting screening at age 45.
And what are the options for screening?
There are several. Colonoscopy every 10 years is often considered the gold standard because it can find and remove polyps during the same procedure. Flexible sigmoidoscopy every 5 years looks at the lower part of the colon. Then there are non-invasive stool-based tests. You can do a high-sensitivity fecal occult blood test, FOBT, or fecal immunochemical test, FIT, every year. Or there's Cologuard, which is a FIFID DNA test done every 3 years.
What about people who aren't average risk?
Right. High-risk individuals need a different schedule. This includes people with a personal history of colorectal cancer or certain types of polyps, a strong family history, especially in a close relative diagnosed young, or those with inflammatory bowel disease like Crohn's or ulcerative colitis. They typically need to start screening earlier, sometimes much earlier, and get screened more often, usually with colonoscopy. Their risk is significantly higher.
And if cancer does develop, what symptoms might show up later?
Things like a persistent change in bowel habits, new constipation or diarrhea that doesn't go away, blood in the stool, which might be bright red or darker, unexplained weight loss, persistent abdominal pain or bloating, any of those warrant a checkup.
Okay. Now let's tackle two conditions that often get confused. Irritable bowel syndrome, IBS, versus inflammatory bowel disease, IBD. What's the core difference?
The absolute key difference is this. IBS is a functional disorder. That means the gut isn't working quite right, it might be overly sensitive, or the motility is off, but there's no actual inflammation or damage to the bowel tissue that we can see. IBD, on the other hand, is an inflammatory autoimmune disease. The body's immune system is mistakenly attacking the digestive tract, causing actual inflammation and damage.
How can you tell them apart?
Diagnostically, looking at inflammatory markers in the blood like ESR and CRP is helpful. They'll typically be normal in IBS, but elevated in active IBD because of the inflammation. Of course, imaging and endoscopy are key for diagnosing IBD. Treatment for IBS usually starts with diet and lifestyle changes, maybe identifying trigger foods with something like the low FODMAT diet. Then medications are used to target specific symptoms, fiber or laxatives for constipation-predominant IBS, antidiarrheals for diarrhea-predominant IBS.
Okay, so IBD is the one with actual inflammation. Let's break down the two main types, Crohn's disease and ulcerative colitis. How do they differ?
They have some key distinctions. Let's compare them. First, location. Crohn's disease can affect any part of the GI tract, literally from the mouth to the anus. It can even affect the liver sometimes. Ulcerative colitis, or UC, affects only the large intestine, the colon and rectum.
Any part versus just the colon. Got it.
Second, the pattern of inflammation. Crohn's often has skip lesions. That means patchy areas of inflammation with normal tissue in between, like islands of disease. UC typically has continuous inflammation, usually starting in the rectum and spreading upwards in the colon without breaks.
Patchy versus continuous.
Okay. Third, the depth of inflammation. Crohn's is transmural, meaning the inflammation goes through the full thickness of the bowel wall. This can lead to complications like strictures or fistulas. UC's affects only the mucosal layer, the innermost lining of the colon.
Full thickness versus just the lining.
Exactly. And finally, some unique signs. Mouth ulcers, called aphthous ulcers, are quite common in Crohn's. UC, as we said, usually starts down in the rectum and left side of the colon, though it can sometimes involve the whole colon.
What are the common symptoms for both IBD types?
Patients with either Crohn's or UC often experience chronic diarrhea, which might have blood or mucus, especially in UC. Also, significant abdominal pain, weight loss, fatigue. And because it's an autoimmune process, they can have systemic symptoms too, outside the gut. They typically have periods of flares when symptoms are bad and periods of remission.
Okay. Lastly, let's touch on celiac disease.
Celiac disease is an immune reaction to eating gluten, which is a protein found in wheat, rye, and barley. It's not just an intolerance or allergy, it's an autoimmune condition where gluten triggers the immune system to damage the lining of the small intestine.
How is it diagnosed?
If suspected based on symptoms or blood tests, referral to a GI specialist is needed. The definitive diagnosis comes from an EGD with biopsies taken from the duodenum, the first part of the small intestine. They look for characteristic damage under the microscope.
And the treat?
The only effective treatment for celiac disease is a strict, lifelong gluten-free diet. Removing gluten allows the small intestine to heal and prevents further damage. It requires really careful attention to food labels and avoiding cross-contamination, as even tiny amounts of gluten can cause problems for someone with celiac.
Wow, we really have covered a lot today, from mapping out abdominal pain to those specific exam signs, acute emergencies, and these complex chronic conditions. Hopefully everyone listening feels like they have a clearer map of their digestive system now, maybe a better sense of what could be happening inside.
Absolutely. And thinking about all this, it really brings up an important point, doesn't it? How does having this kind of detailed knowledge about symptoms, signs, treatments empower you, the listener, to be a better advocate for your own health? And crucially, when should you stop trying to figure it out yourself and absolutely seek immediate medical help? Something to really consider.
Definitely. Remember, this deep dive is all about understanding, about gaining that knowledge base quickly but thoroughly. We really hope it sparked some aha moments for you today and gave you plenty to think about. Until next time, keep that curiosity ignited.